focus on the future of healthcare within the next 5 years, and to assess how the impact of so many of these emergent technologies, some of which you've heard about here this morning, will frame that future. What is it going to look like? And we're receiving an overview of this future influenced by technology from three pretty different perspectives. One is from a practicing physician who's nationally recognized clinician and researcher in oncology and leads an international effort studying the future of healthcare policy globally. Another who is a serial entrepreneur and has taken worldwide companies to the next level in engaging consumers. He's done this internationally, and he's now tasked with taking a health insurance company involving consumers in innovative ways we really haven't seen before. And our final panelist has held very high positions in government, both at the federal and the state level, being the architect of sweeping changes in how the public is insured, how it's regulated in the industry, and protected and funded to receive health care. What we're going to do is open our discussion with about a 5-minute presentation from each one of our panelists, and asking them how they see these technologies impacting healthcare from each of their perspectives. And then we'll talk more as a group and have an exchange here on discussing how these technologies will impact the greater good, or won't they? And so we'll discuss that. So first, we're going to begin with Dr. Guo. As a practicing physician, and he's a researcher in lymphoma at the University of Hackensack Medical Center. He's also co-chair of the Global Council on the Future of Health and Healthcare for the World Economic Forum, and the recent lead author of a report on that same topic that was just issued, looking at the future of healthcare globally. So Dr. Guo, we're very anxious to hear your...
Good afternoon, everyone. This is a very exciting forum. This is the best time to be in medicine. I'm not biased. And I'm not going to tell you something you don't know, that healthcare is broken, that we can't continue the way we do. But we also, although we all know that we have to do something differently, we really don't really know well on how to do this for a number of reasons. And healthcare has not made a lot of progress. It's behind, particularly in data, because of this partially. One of the big issues in healthcare is the fact that people look at the consumer, the patient wants the best outcome, obviously, but the system is very fragmented, the healthcare is fragmented, and the stakeholders in healthcare are misaligned. However, the acceleration of problem in healthcare I see it as an opportunity for a number of reasons. I would say there's 3 types of factors that are going to force us to change healthcare. The first one is affordability/burden of healthcare and healthcare-related issues. So first of all, the aging demographics, 10 million people by 2050, there will be more than $30 million centenarian by 2100, and by 2050, 2/3 of the population would be more than 60. So this is definitely a factor with all the chronic disease. NCD, non-communicable chronic disease, represent more than 75% of healthcare costs. And there's an acceleration of diabetes, cancer. Cancer will increase in incidence 80% in the next 20 years. So this is a major factor. But we also look at other issues like infection. Antibiotic resistance will become the first cause of mortality worldwide by 2050. And when you look at this, how can we afford this? The cost of medicine has continued to increase, 18% of GDP. This is $50 trillion worldwide in the impact of healthcare, and it's going to continue to rise, obviously, with the cost of non-innovation. The second aspect is the exponential acceleration, really, sort of pleonasm of the innovation. So from the human genome, that 20 years ago, that was $3 million, and then 10 years of work, and now this is less than an hour a day, less than an hour soon, and then it will be less than $100. So human genome, better understanding of disease, particularly in cancer, immunotherapy, cell therapy, regenerative medicine, metabolomics, omics, all of this offers new field in medicine. So this innovation will bring innovation to patients that are game changers, but have a cost, and how we afford them. And the third aspect is really the digitalization of healthcare, from the wearable, social media, hyperconnectivity, Internet of Things, in the context of the 4th Industrial Revolution and all that. So all of this on how this is forcing us to try to relook on how we're going to deliver healthcare. We have to change this to make it away from just brick and mortar centric healthcare to patient-centered in their ecosystem. And I'm going to take an example, not cancer, not because I'm an oncologist, but I think it's a great disease to look at this because there's an opportunity to make things better. for a number of reasons. We have to stop thinking of cancer as one disease that we treat. We have to think of pre-cancer, both in terms of prevention, but early detection more importantly. Cell-free DNA will offer us an opportunity in the future to detect cancer before it becomes a detectable cancer. And I'm convinced that better genetic screening and recommendation will have ways to mitigate some of these early cancers. But the post-cancer is when someone has 6 cycles of X, Y, and Z for a treatment. They could come and actually be evaluated for measurable residual disease or still residual microscopic disease that 100% would relapse. And immune intervention. If you look at the immune status of someone post-chemotherapy, based on some parameters of the immune status, the survival for complete remission patient is from 5% to 90%. So this is a very big opportunity to do something. And then the third aspect is the treatment itself, and that's where the problem is currently in the short term for the next 5 years. And I think this is really to take action around data, to try to make data shareable, to work on privacy, we collect tons of data. Obviously, the problem is that what is the quality of this data and how these data are actionable. So one of the initiatives that we have taken in our institution and actually is develop a platform analytics where we stratify patients based on the ultimate known of the time clinical, biological, and molecular factors that can predict the outcome of a patient. So this is allow us to give a code to a patient and to follow the journey of a patient over time and try to answer several questions. One, what is the best treatment when you see a patient? Because there's a menu that is getting longer and longer options. Among the best top treatment, for example, top 3 treatment, what is the more treatment cost effective? Right? Reduce the variance of the decision by providing supporting decision at the point of care and supporting information, valid information for patients to be informed in their decision by rationalizing the decision by opposition to rationing care. By making treatment decision better and smarter medicine, we will have a better outcome at the individual level, and that's what patients want. They want value-based care. And value-based care is not reductionist. Value-based care is smarter medicine to improve the outcome at the level and reduce the cost along the way for the population. And that's where the future is, and this is very important because the other aspect that's really critical is that among the we have not only a huge menu of options. Just to give you an example, non-small cell lung cancer, 79 options to treat non-small cell lung cancer at this point. So the number of options that you have to treat someone when you look at outcome, we need to identify what's the best sequence of care. And finally, this data should capture the patient's behavior, compliance to treatment, adherence to treatment, but also well-being of treatment, on treatment and post-treatment to improve survivorship and outcome. So we have an enormous amount of technology to try to look at the entire journey of a person from wellness prevention to early disease, treatment of disease, and long-term survivorship. And that's where we have to go because that's and providing patients with relevant information at the point of care and physician for better decision as well. Smarter medicine is always better medicine.
Thank you, Dr. Waugh. Ivan, you are the Chief Marketing Officer of the next-gen health insurance company, Oscar Health, that Google, you saw, just invested $375 million in. That's going to allow you to have more technologies and adapting those to further your mission, which you stated as it's centered on the patient and will make our healthcare system work for consumers. One of the things that you're doing is, bringing a fresh vision to certainly with healthcare insurance, because for those of you in the audience who don't know, Ivan was the Chief Marketing Officer for Old Navy, for Converse, and for Cole Haan, and he's bringing this different kind of lens and perspective to healthcare insurance.
It's me, unqualified to answer any of those questions.
Right.
So I'll probably answer more from a technology perspective than a healthcare perspective. So yeah, Oscar was started 6 years ago by my boss Mario, who's an engineer. So it's a full stack engineering company, really, sort of posing as a health insurance company. So obviously we have a strong point of view on technology and the role that it can play in driving clinical outcomes. But for us, the way that I'd rather answer this question is less about how can technology or what effect is technology going to have in the next 5 years, which is a pretty monumental question to try and wrap your head around. For us, it's more about how exist to do that, either for our members or for ourselves or for the intermediaries and the providers. So there's luckily, you know, I think everyone will agree, wherever you sit on the political spectrum, that is the problem with healthcare, right? It's hugely bloated. There's a ton of friction in the system, and technology can be brought to bear, I think, in lots and lots of different ways, actually, to take costs out of the system. So I'll mention a few of them that we're focused on. Three probably. We'll see how much time I have. We've got 5 minutes. Okay. So virtual care, telemedicine is something that we've invested a lot in since the early days. I think Oscar was the first insurance company to offer free telemedicine to all of our members, and now we have more people working actually out of Tempe, Arizona than we do in our HQ. We have about 700 people now in Tempe, Arizona running concierge and nurse practitioners, and our telemedicine center runs out of there. So to put that into context, about 30% of all our members use telemedicine now, which is significantly higher than anyone else in the industry. I think most other players are in the low single digits, but I think we're probably on the trend curve of where the rest of the industry is going from a telemedicine perspective. So, you know, I wouldn't be surprised if that gets up above 50% in the next, you know, sort of 5 to 10 years. So telemedicine is, you know, coming out of the, I think in Amara's law, you know, coming out of the sort of trough of disillusionment and is actually prime time now. So its moment has come, and I think it's becoming the predominant way that a lot of people do seek care. We just last week, actually, just sort of as an extension, sort of a first cousin, a closely related cousin to telemedicine is virtual primary care. We launched that last week for the first time, so we had an in-home visit that was facilitated by a nurse practitioner, but this is somebody who had a sort of a fairly chronic condition and needed ongoing care, and the doctor was facilitating that remotely. That's a huge area for us. We were just talking about it prior to the session. I think it's got huge implications for the aging population and for the MA audience, anybody who needs ongoing care. So virtual primary care, I think, is going to be you know, a sort of a huge area, not just for us, but for the industry at large. So those are two sort of big investments from us and from a technology perspective. Second one I'll talk about is just sort of finding care in general, or care routing. So if you think about how you look for a restaurant or decide where to eat relative to finding a doctor, and the discrepancy there is pretty huge. You know, in terms of a restaurant, you could look for, you can really decide how you want to search for a restaurant. You know, is it based on price? Is it based on quality? Is it based on, you know, user reviews? Compare that to finding a doctor. It's very, very opaque at best. I'm being polite about it. But very difficult to link sort of clinical outcomes to cost, for example. You know, I want to find the best doctor who's performed this operation more than anyone else, who's close to me, who has availability at 2 p.m. on Monday, but is also within a certain price range. Almost impossible to do that, but we can do it through our app, you know, really in a very seamless way, so that you can search by those criteria and find a doctor and book it, you know, through the app in a couple of minutes. So that's kind of a big area of investment for us. And if I have time, one more. Drug costs. So because we're full stack, we can see a visibility of the data upstream and downstream, meaning we can see provider level data and also patient level data. So what we did we're kind of keen on reducing drug costs. It's a big pain point for our members. So what we did is we looked at we took basically all of our members and looked at the most commonly prescribed drugs for the clinical incidents that they had, boiled that down to a list of 300 drugs that cover the majority of cases. Actually, more than 80% of all clinical cases are covered by the 300 drugs that we identified. And then we took the actuarial risk, which is a fancy way of saying we covered the cost of those drugs, and took them down to $3. So if you happen to be needing one of those drugs, which in 85% of cases, that for our members that is the case, your drugs will cost $3 now, instead of, you know, some of the cost of those drugs. I think there was an insulin drug on that list that cost $250 or more. So we were able to introduce drug costs at a flat fee of $3 for all our members. So that was a way that we were able to use data to identify the risk, and it kind of gets at value-based care, which is what you were talking about, which I think is the North Star that a lot of people are kind of struggling towards or grappling towards, but it's complicated. But it sounds like a crazy thing to do, to reduce all of our drugs down to $3, and it kind of is a crazy thing to do. But the risk outweighed, or the reward outweighed the risk in our case. case because we were driving healthier outcomes. So at the end of the day, you know, it's much better for us to have a healthy population of people who are taking the right drugs in the right quantities at the right time than have people who are actively avoiding taking drugs, which is what happens with a lot of people now. I think there was a recent study, more than 50% of Americans say that they avoided taking drugs in the last year because they were worried that they couldn't afford them. So, you know, having people take a generic alternative or just an alternative drug, or actually the same drug but it's reduced in price, leads to better clinical outcomes, which leads to healthier members, which means that, you know, everybody, it takes friction out of the system. So that's probably it. I'm probably out of time.
Yeah, that's great. That's great. We'll go on then to Jay. You've been the former head of regulatory implementation of the Breakthrough Affordable Care Act, Obamacare, at HHS, and the former state insurance commissioner in not just one state, but 2 different states. And so in those roles, you've enjoyed a strong reputation as a consumer advocate, and you're credited in large part to crafting ACA's Patient Bill of Rights. And so from your public sector lens, how do you see the future of healthcare?
Yeah, like everyone else, I've got my biases, and my biases are based on what I've been doing for the last couple of decades. As Linda said, I've been an insurance regulator. Now I'm a plaintiff's lawyer. I generally sue insurance companies, so I want to make that bias clear. It's my view that in the last 5 years, the innovation, the technological advances, the innovation that we've seen in the insurance industry, whether the health insurance industry or auto, property, casualty, other types of insurance, those advances in technology have been very good for the companies, but they have not furthered the greater good. To the contrary, with so much data around, with so much more technology, insurance companies have just become better and better at weeding out the sick to the extent that the law allows it, and to the extent that the law doesn't allow it, and Obamacare doesn't allow it or tries not to allow it. They've been very good at designing their benefit, based on how much data is around, designing their benefit packages in such a way that they do not cover what people really need, but they do cover what people think they need. And so during the Obamacare, the debate about Obamacare implementation and how prescriptive the government was going to be about how insurers design their benefit packages, there was a big debate about standardization. Should we try to commoditize everything, make everybody sell the same thing or the same 2 or 3 things? And the argument there was, when you do that, price, they have to compete on price. They have no choice. What the industry argued, and the industry really has, I think, the better of the, I don't think it's really the better argument, but it's got more popular appeal. All they have to do is shout choice. We're depriving people of choice. We want an unlimited number of benefit packages because what's good for you isn't good for him. And we don't want one size fits all. So the industry is just terrific at this rhetoric. And in general, it carried the day. Not in all states. There's some standardization, for example, in California and a couple of other states. But in general, the federal Obamacare exchange is not what it could be. If it commoditized the product, I believe really prices would come down. It doesn't. And so it allows insurers to compete on bases other than price. I'd like to generalize that a little bit to other types of insurance. Auto insurance, for example, auto insurers have become better and better at the same thing, at weeding out bad risk and just breaking the people that they insure down into smaller and smaller categories. And so in the old days, insurance was based purely on risk. I mean, how much you got charged for auto insurance was based to a large extent on your driving record and where you lived. You know, how obviously if you live in an urban area, you're more likely to run into another car than if you live in a rural area. But in the last 20 years, insurers have been using other factors which aren't intuitively obvious, such as credit history. I mean, you wouldn't think that credit history has anything to do with how good a driver you are. And it's counterintuitive, but the insurers have data which shows that credit history is a very, very good predictor of whether or not you're going to be in a crash. And what the insurers say is, you know, we don't know why this is true. We don't care why it's true. All we know is what the data show us. And they're right on that. Now, in some states, as a matter of public policy, the state has prohibited insurers from using credit. But in general, they've won that battle. I mean, that's a small minority of states. The next step is this, and I'll stop after this. I've got a real interest in this area because we're involved in several cases challenging this practice. You don't see it, I don't think, too much in health insurance. You do to an increasing amount in auto insurance and homeowners insurance, and most people are unaware of it. And that's this. There's so much data around now that insurers can tell not just how likely you are to have an accident or how risky your house is, but to what extent you'll tolerate a price increase. That is, how willing you are to pay more than the risk you present justifies. Unlike other industries, insurers must charge rates by state law that are not excessive, inadequate, or unfairly discriminatory. Those are terms of art. But what it means is you have to charge somebody based on the risk he presents. Well, insurers now are trying to get around that, and they are charging people based on the risk they present. But if you are a loyal customer, if you've been with a company, say, for 10 years, they know you're likely to stay with the company as long as they don't raise your rate. You know, let's say the data show that you ought to get a rate decrease of 8%. But they've got data showing that the group of people, say, that have been with the company for 10 years, most of them are going to stay with the company if they get a price increase of 4%. So that's a tremendous frontier for the insurers. It's just starting. I don't think it exists too much in the health insurance industry. So these are the things that technology has allowed insurers to do. Now, in the next half of our discussion, I'd like to propose some solutions. I just don't want to talk about how bad things are, but that is the way I think things are today.
That's great.
Yeah, I want to comment on that. I really appreciate the perspective. I think I alluded to smarter care. I think this is really important to talk about medical education as well. I'm trying to engage people, and we talk about novel profession, that it will be people more focused on data, behavioral, community supporters, and all that. But if you look again in cancer, we talk about 80% increase of incidence in cancer in the world, 75% increase mortality in the next 10 years globally, particularly in the emerging countries. So this is a huge burden. But when you look at it, half of these 40% of these cancers are preventable with lifestyle changes. So we think of a disease as a disease. We need to look at the entire spectrum, obviously, from lifestyle, and have ways to incentivize people to try to do this, and that's where the behavioral changes will happen. There's an interesting early data called the Pioneer Study, piloted by Lee Hood in Seattle from the Institute of System Biology. So they took 1,000 normal individuals, put them on Fitbit, Facebook, in a cloud, and obviously consented, and then they approached remotely on the phone or face-to-face, and then monitored every 3 months extensively biological, microbiome, and all that. 100% of the first normal individual between 20 and 35 had actionable items. 100%. So if you try to change their lifestyle, and then show them 3 months later that their biological values are back to normal, this is a huge encouragement factor to try to adhere to the changes of the lifestyle. Because we always talk about prevention. All the campaigns are very short. We all know it's bad to smoke or do the wrong thing, but we still won't, a lot of us do it. So this is one aspect of cancer, but the other aspect is for the treatment. It's really unfair in the way that we promote TV and all of that, we promote everywhere in the news that game-changing therapies like CAR T cells that save about 40% of patients who would have no option in refractory leukemia or lymphoma. The cost is outrageous, $475,000 plus for the drug, plus sometimes $1 million for the administration on the floor, if there are complications. So we do this, and it's a Medicare disease because aggressive lymphoma is median age is 60, 65. a diagnosis of having a relapse, definitely it's a Medicare population, and we cannot do it. We had over the last 2 years waiting lists of patients, and they can't wait forever because they obviously die of their disease. So this is a real effect. And an aspect, the government approves the drug, Medicare approves the drug, and we don't have the coverage for a drug that is a game changer. Why I'm giving this example is it's a sort of a caricature example in a way, but at the same time, we started to look at the cost. If you continue to treat a patient without using this expensive therapy, but continue to treat them with additional therapy, they don't survive necessarily long, but maybe 6-8 months. You spend almost the same amount of money by doing this. So reshuffling the deck is very important. And the last comment is also again on smart medicine. We did a study on 1,500 lung cancer, looking at diagnosis, the patients who actually got molecular testing to guide the treatment. 40 to 60% of patients in the real world did not get any molecular testing for a number of reasons. If you had a molecular testing and had a targeted therapy, which is a pill, the median survival was 4 years. If you didn't have it and got your own chemotherapy, the median survival was 10 months. And the cost in 10 months was way more than 48 months of survival at home. So those are things that are very important. In a big picture where out of the $3 trillion that we spend, 1/3 is wasted in healthcare. In oncology, 40% of what is spent has no impact on the outcome. Because a drug is approved based on a response rate of 30 to 50%, that means it doesn't work in 50 to 70% of the patients. But we still use it because it's approved for that disease. So this is really important and insist to get real world data to try to find the best sequence of care, but look at the cost of the entire journey. And I don't know what you think about the reimbursement of the entire journey of a treatment versus looking at a specific drug that might be very expensive.
That's outside of my area of expertise to comment on that, but I think that in general, yeah, I mean, figuring out how to make value-based care, economically viable is something that I think we all need to work on. I think the providers as well are, critical component of that. I mean, it can't be done alone by the insurance companies. It has to be done in combination with the providers. So.
And it seems like a thread here is on data, right? I mean, so on data analytics, and that's something that you're looking at. But then how do you influence and use that knowledge for consumer behavior? I was at Mount Sinai recently. It was a project, and they had showed where is this still on?
Yeah.
They were very interested, of course, of what was the incidence, or how could they predict whether or not a patient would get a staph infection. Something that's maybe every hospital doesn't want to have to experience, and certainly the patients don't either. And so they really got involved in predictive analytics and working with a lot of the clinicians and the nurses. Everyone was involved. And they ended up discovering that folks who were coming in that were malnourished had a higher incidence of having a staph infection. So now that's all now part of their assessment as soon as someone is admitted to the hospital. So there are some things that are very helpful with all this predictive analytics, but you're also identifying, but this can also be used in terms of data in a way that really doesn't serve the patient's interest either, or the consumer's.
We made a observation in immunotherapy that you game changer. Lung cancer, some patients can cure melanoma even if they have brain mets. So it's quite remarkable. We looked at the outcome depending on zip code. And it seems obvious in a way that you say in difficult zip code, maybe the outcome is going to be worse. That was the case. And it was not for the time to get the treatment, delay in therapy. This was actually for a poor immune response to the immunotherapy because of malnutrition. So this is really important that we stop thinking of the disease of a slice of a body, think of the entire ecosystem, because that's what's going to prevent patients get readmitted. We need to readmit it or retreat it or relapse and all that. Physical exercise, a simple thing. I recruited a guy from Emory. He has a lot of research report to look at the impact of physical exercise on the outcome of patients with chemotherapy. In every disease we tested, the outcome is better. You say, well, you're in better shape, you're in better condition, you have less chronic issues and all that. There's better survival and less relapse. So this is obvious. Those are things that are obvious. But how do you put this in perspective when a patient is going to be depressed? Who's going to push them to try to do it and all that? So that becomes very difficult.
I think, how much more time do we have? And do we change? About 10 more minutes or 5 more minutes? Oh, okay, great. Well, why don't we talk about, some of the things that, we've seen how technology is going to advance things. You're going to be getting more information from consumers, and how do you develop a product that will really help them in their journey of becoming, more healthy. And, especially it was fascinating with your family virtual visits, which is very important, especially for an aging population. So we see some of the positive things, but are there some things that you're worried about? I know Jay has certainly identified some in terms of how we're paying for this care and making those kinds of decisions. So I thought maybe we'll just have our discussion now, like, well, we're going to have all the, things with the Internet of Medical Things and the wearables and the data analytics and IBM Watson, but I've also, talked with radiologists who are a little concerned with IBM Watson because, anything that's repetitive, and you can develop an algorithm, and they're getting all this, phenomenal big data from Medicare, they're able to diagnose and pick up tumors as accurate and sometimes even more so than a physician. So all of a sudden, it's not just the orderly in a hospital, the transporter, who's concerned seeing all of the robotics delivering everything throughout the hospital system, but it's also physicians. So what are some of your thoughts of how you see that future playing out? What's the greater good? What's jeopardized?
I'll probably have the shortest answer. I think, certainly is technology, of course, ultimately of good, or is it, pernicious and dangerous? I think it's a kind of, there's obviously no clear answer to that. I think the way I always think about that question is that, do the ends justify the means, or is the greater good outweigh the possible negative consequences of it? I don't think there's probably anyone who would disagree that the advent of cloud-based computing and neural networks has led to greater efficiency of decision making, and that's having all sorts of impact, not just in healthcare but in many industries. That's kind of like goes without saying. The question is, do the potential, live in a world where anything that can be hacked will be hacked eventually. So, could personal information be, fall into the wrong hands and be used against people? That's obviously is always a danger when you're dealing with, large bodies of data, which is what this industry is built on. So, yeah, of course there are downsides to that. The evil companies could use that information to sort of construct products in a psychologically motivating way, or even worse than that, the data or information could be used negatively against someone to stop them from, getting a job or getting health insurance. So yeah, there's a downside. But there's a huge positive upside as well to the information age that we're living in.
Did you say evil companies? Is that what you said?
I did not say.
Okay. My point isn't that the companies are evil at all. Going back to what one of the gentlemen on the previous panel said, he said something about how you need regulation of some kind, or smart regulation. You don't want to kill the golden goose, which I sort of agree with. I guess I'd say this. In this country, as much as some of us might be in favor of Medicare for all, the only reforms that have been passed and that have had some effect on driving down costs and arguably improving quality have been those reforms where there is bargaining power that structures the market in a way that the incentives work to drive down costs. So that's what managed competition obviously is based on. It's what the Massachusetts system was based on. It's what the Obamacare is based on, although obviously it's not a very pure example. The purest example that I know of was in Missouri, where in the 90s, where I was commissioner, and Governor Carnahan was the governor, and he's the guy who pushed it, where we implemented the textbook model of managed competition, in which we did standardize the benefit package, complete standardization, and we said to all the insurance companies in the state, all the HMOs in the state, give us a price at which you will insure any state employee, and the low bidder, the state will pay the price of the bid of the low bidder, and anybody who bids higher than that, the state employee has got to pay the difference between the low bidder's bid and whatever the bidder's bid is. That's the classic managed competition where there's just a tremendous incentive for an insurance company to bid low because that low bidder is going to get so much more business. And it worked. I mean, it worked beyond our wildest dreams. It cut rates by almost half in some regions of the state. So that's an example of managed competition working. There's also obviously big businesses and business groups band together. There are a whole bunch of ways to pool bargaining power, and ideally, and this might, I think, really might be the best hope for the future, is to structure the market so that the insurance companies have no choice but to control costs, to really drive down the costs of the providers, because if they don't do that, they're not going to survive. Now, in order to do that, you've got to have a pretty tough series of government rules. But if the insurance company, in my view, the insurance companies are here to stay. There's not going to be any Medicare for all. There's not going to be a single payer system. So the trick is for government to structure the rules so insurance companies will actually do some good.
Yeah, by the way, I totally agree with that. I think that some combination of state regulation and private enterprises is the right way forward. So, yeah.
It sounded like your focus is finding the friction. It's not always the government pushing you to do that, but you're finding friction that you can change.
Yeah, I mean, if you have a complete absence of government regulation, you get things like these short-term health plans that spring up, which is sort of like the equivalent of a loan shark, where there's no regulation. So God help you if you get sick on one of those plans. I mean, you're not going to get covered at all. So you definitely need regulation, but there's room for private enterprise, I think, to encourage innovation around that.
Mm-hmm. We do have I think about 5 or 10 minutes, so questions. Why don't you go first and then you second? Go ahead.
You talked a little bit about Medicare for all. Can you tell us your opinion about Medicare option?
Oh, you mean what do they call it? The Medicare option, the public option, right?
As an option.
Yeah.
Not as a requirement. So if you want to keep your insurance, you keep your insurance. But if you want to take option Medicare, and I'm not talking about the first 100 days or first year, permanent option.
Yeah, I think it can work, but you've got to make sure that it's not designed to fail. What the drafters of Obamacare, what Congress did with Obamacare, is they set up what were called consumer-operated co-op plans, and they were sort of a sort of public option, but they set up the rules so that they couldn't succeed. And my fear, for example, they prohibited them from spending any money on marketing. They prohibited state insurance commissioners from putting out rules that would benefit them. So they were designed to fail. The private market signed off on that. That was their provision. What I'm afraid of with a public option is that it would end up so that the public option ended up with the bad risk and the private insurers took the good risk. Because, it's a cliche in the industry, you want to socialize the risk and privatize the profits. And that's my fear of what would happen. Doesn't mean it shouldn't be tried, but that's my fear of what could happen with a public option.
Your question.
Yeah. So the concept of comparing insurance companies so that you could pick an insurance company that would have the basically lowest administrative costs is what you're aligning. In other words, it's impossible at this time, having tried myself as a doctor and now as a patient, to compare insurance companies and use any logic except maybe what hospital they're associated with. You can't, outcomes are not comparable. You have no idea, I have no idea as to what, in case something happens, will they approve this drug or that drug? It's absolutely impossible to find. So to me, the only solution is, as you described, to mandate coverage of everything the same. You can have different insurance companies trying to use digital mechanisms to try to improve my various ways of keeping my health. But what about, for example, the doctors in the hospitals? So does one insurance company still have only, I wanted to look at Oscar, for example, for my wife. Oscar doesn't, I'm not sure, but as I remember, doesn't associate with Columbia University doctors as a rule. So if you don't have them all associated with the same, and mandate that they all have access to the same physicians and the same hospitals, again, you're in the same situation. You'll never be able to compare them. So I'd like to hear the opinion of mandating. The insurance company then becomes basically like a supermarket. They all keep the same stuff there, but they have their own way of bringing it in efficiently. And so.
Let me say one thing and then I'll shut up. The theory of managed competition, though, is exactly what I think you don't like. The insurers, the idea is that insurers do compete on network, that somebody, I mean, in St. Louis, for example, well, Boston, most people know Boston. So Mass General's the big hospital there, but there are other hospitals too, and not all insurers have Mass General. And so it's up to the consumer. Do you want to go with Oscar, which has Mass General, or you want to go with somebody else that has St. Elizabeth's or something? So it's not, I mean, so the theory of managed competition is that there are groups of providers that compete against each other. And it's not going to work, obviously, in rural areas, but it can, and it has, to a certain extent, in urban areas.
I think the answer to this is to have a way to measure the outcome at the individual level, based on clinical, biological, molecular markers that compare cohorts that are identical. So we compare apple with apple. And then you can look at all the menus to treat the disease X, Y, and Z, and say those are the top 3 treatments, and be transparent about the data. And then you can compare, and then, because so far at this point there's no transparency, there's no measurement of the outcome, and it makes it very difficult. No question about this.
Yeah, would you like to answer a quick answer?
Yeah, and then I think we're about ready to close.
Okay, yeah. I mean, I feel your pain. It's very difficult to compare one insurance company against the next. I think you can look at healthcare.gov and it'll give you some plan comparison, but it doesn't publish like claims data, for example, which is what you probably really want to be looking at. I mean, the idea is, it sounds good in theory to require all insurance companies to essentially offer the same product and then could normalize prices, but as discussed, the offering of insurance companies is different because each insurance company can choose to partner with a large network of providers and cover every single hospital in the New York network, or a very narrow network of providers. And in order to achieve what I think you are suggesting, probably every insurance company would have to partner with every provider in every market in order to normalize the prices, which means that the risk pool would be equally shared, which would be easy from a consumer perspective to have complete visibility, but it wouldn't allow any competition from a network perspective. So in Oscar's case, for example, we've gone into certain markets and constructed very specific networks using certain providers that we think are best in class, as opposed to going in and contracting with every single provider. If everybody shares the risk pool equally, then it will be very expensive.
Okay, well, thank you very much, and I really want to thank our 3 panelists. You did a wonderful job.